Hypotension is one of the most common and most dangerous problems we encounter in clinical medicine. But at the bedside, low blood pressure is not a diagnosis. It's a clue, a signal that something in the circulatory system is failing. In this video, we're going to walk through a practical, physiology-based framework for understanding hypotension, the same approach I use on rounds and teach in frameworks for internal medicine. We'll start with a real clinical case because hypotension only becomes meaningful when you see how it presents in an actual patient. From there, we'll build a simple but powerful framework that divides hypotension into 4 major categories, each one representing a different failure point in the cardiovascular system. Let's start with a case from frameworks for internal medicine. A 48-year-old man with a history of hypertension and diabetes is admitted to the hospital with episodes of chest discomfort that developed over the course of a few days. The pain is located in the center of his chest with radiation to the jaw. Its pressure-like in quality, has been intermittent for a few days but is now constant. He's also short of breath and feels lightheaded. He smokes 1 pack of cigarettes per day but denies significant alcohol use. His father died of an MI at age 52. His heart rate is 144 beats per minute, and his blood pressure is 70/40 millimeters of mercury, similar in all 4 extremities. His respiratory rate is 36 breaths per minute, and his oxygen saturation is 88% on 4 liters of supplemental oxygen. Jugular venous pressure is elevated to 16 centimeters of water. An extra heart sound is heard just after S2 with the bell of the stethoscope over the apex. There are bilateral late inspiratory rales. The extremities are cool to the touch and the peripheral pulses are weak. His electrocardiogram is shown here. A chest radiograph shows bilateral patchy ground glass opacities with bilateral pleural effusions. So here's the question we'll come back to. What's the most likely cause of this patient's hypotension? Before we build a framework for hypotension, we need to anchor ourselves in a few core physiologic relationships. Mean arterial pressure, the pressure that actually drives blood flow to organs, is determined by 2 things: cardiac output and systemic vascular resistance. So we can think of it as simply MAP equals cardiac output times systemic vascular resistance. And cardiac output itself is a product of heart rate and stroke volume. So now we've broken blood pressure into 3 major physiologic levers: how fast the heart is beating, how much blood is ejected with each beat, and how constricted or dilated the arterial system is. When a patient becomes hypotensive, one or more of these variables has failed. The entire framework we're about to build is really just a structured way of asking which of these levers is the problem. Now, of course, blood pressure is not static. The body is constantly adjusting it through several tightly coordinated systems. The nervous system plays a rapid role through baroreceptors, which sense changes in arterial pressure and adjust heart rate, contractility, and vascular tone through sympathetic and parasympathetic pathways. At the same time, the kidneys and hormonal systems provide longer-term regulation. When blood pressure or effective circulating volume falls, the renin-angiotensin-aldosterone system is activated. This increases vascular tone and promotes salt and water retention, helping to restore blood volume and pressure. So blood pressure reflects a balance between cardiac performance, vascular tone, and circulating volume, all under continuous neural and hormonal control. Hypotension occurs when these compensatory mechanisms are overwhelmed, impaired, or working in the wrong direction. And that's what will allow us to divide hypotension into distinct physiologic categories. Now that we've reviewed the basic physiology, we can build a practical framework for hypotension. At the bedside, nearly every case of hypotension can be understood by asking which part of the circulatory system is failing. And that leads us to 4 major physiologic categories. The first is hypovolemic hypotension, where there simply isn't enough circulating volume to fill the vascular system and support cardiac output. The second is cardiogenic hypotension, where the heart itself is unable to pump effectively, so cardiac output falls despite adequate volume. Third is distributive hypotension, where the problem isn't the heart or the volume, but the blood vessels. Systemic vascular resistance falls because of pathologic vasodilation. And fourth is obstructive hypotension, where blood flow is physically blocked somewhere in the circulation, preventing adequate cardiac output, even though the heart muscle and volume may be normal. These 4 categories are not just lists to memorize. Each represents a distinct physiologic mechanism. So next, before we start filling in specific diagnoses, we're going to walk through how each of these categories actually lowers blood pressure. Once the mechanisms are clear, the differential diagnosis becomes much easier and much more intuitive. Now that we've outlined the 4 major physiologic categories of hypotension, the next step is to make this framework usable at the bedside. When you're evaluating a hypotensive patient in real time, you don't start with a long differential diagnosis. You start by asking a few key physiologic questions. This table represents the three major variables we try to estimate clinically. First is central venous pressure, which we approximate using the jugular venous pressure. This gives us insight into filling pressure and venous return. Second is systemic vascular resistance, which we often infer from the patient's extremities. Are they warm and vasodilated or cool and vasoconstricted? And third is cardiac output, which we estimate from overall perfusion. Things like pulse strength, mental status, and evidence of end organ blood flow. These bedside observations correspond directly to the physiology we reviewed: preload, vascular tone, and forward flow. What we're going to do next is walk through each of the four categories of hypotension and predict how these three variables behave in each one. Once we understand the mechanisms, the patterns in this table will start to make intuitive sense. In hypovolemic hypotension, the fundamental problem is loss of circulating volume. With less blood returning to the heart, preload falls. That means stroke volume falls, cardiac output drops, and blood pressure decreases. Because the body senses this fall in pressure, it activates the sympathetic nervous system. Systemic vascular resistance increases in an attempt to maintain perfusion, which is why these patients often have cool, clammy extremities. And since the issue is volume loss, venous pressures are low, so the jugular venous pressure is typically reduced or flat. So in hypovolemic hypotension, we expect low CVP, high SVR, and low cardiac output, with 2 down arrows for CVP because that's the fundamental problem. Let's pause for a moment here and look at how this plays out at the bedside. In hypovolemic hypotension, we said filling pressures are low, and the best way to estimate that is by examining the jugular venous pressure. In this video, you can see my finger pointing toward the internal jugular venous pulsation on the left side of the patient's neck, just above the clavicle, while he's in the supine position. Next, my hand goes toward the patient's chest to find the angle of Louis, our standard reference point for estimating JVP, which is roughly 5 centimeters above the middle of the right atrium in this position. From the angle of Louis, I slide my hand horizontally toward the patient's neck. Normally, in a patient with adequate filling pressures, you'd expect the top of the venous pulsation to be visible at least above this level. But in this case, the venous pulsation is quite a few centimeters below the angle of Louis. That tells us the jugular venous pressure is low. That's exactly what we'd expect in hypovolemia. There isn't enough circulating volume to fill the venous system, so right-sided filling pressures are reduced. Now let's move to cardiogenic hypotension. Here, the problem isn't a lack of volume, it's pump failure. The heart is unable to generate adequate forward flow, so cardiac output falls. Because blood is not being effectively ejected, pressure backs up into the venous system. That leads to elevated filling pressures, which we see clinically as an increased jugular venous pressure. Despite this high filling pressure, forward flow remains poor, so cardiac output is low. Peripheral pulses are weak, and signs of end organ hypoperfusion may be present. The body responds to the falling blood pressure by activating the sympathetic nervous system, which increases systemic vascular resistance. That's why these patients typically have cool, clammy extremities, similar to hypovolemic shock. So the key pattern in cardiogenic hypotension is high CVP, high SVR, and low cardiac output, with 2 down arrows under cardiac output because that's the fundamental problem. Here we see an example of an elevated jugular venous pressure. In this patient, even in the upright position, the jugular venous pulsation is visible high in the neck, approaching the level of the angle of the jaw. That indicates markedly elevated right-sided filling pressures. This is what we expect in cardiogenic hypotension, where the heart is unable to pump blood forward effectively. Blood backs up into the venous system, leading to venous distension. So in a hypotensive patient, a clearly elevated JVP like this is a strong clue that the problem is pump failure, not low circulating volume. The tank isn't empty, the heart just can't move the blood forward. Now let's look at distributive hypotension, which is physiologically very different from the first two categories. Here, the primary problem is not low volume and not pump failure, it's pathologic vasodilation. Systemic vascular resistance falls because the arterial system loses tone. When vascular tone drops, blood pressure falls even if cardiac output is normal or even elevated. In fact, early in distributive shock, the heart often responds with an increase in cardiac output, so peripheral pulses may actually feel bounding rather than weak. Because the vascular space is suddenly larger, effective circulating volume is relatively low, so filling pressures can be reduced and the jugular venous pressure may be low or even normal. And since the vessels are dilated rather than constricted, these patients typically have warm extremities, a key contrast with hypovolemic and cardiogenic shock. So the bedside pattern in distributive hypotension is low SVR, relatively low or normal CVP, and often a normal or high cardiac output, with 2 down arrows for SVR because that's the fundamental problem. Here we see an example of Quincke's pulse, or visible capillary pulsations in the nail bed. You can see rhythmic flushing and blanching of the nail bed with each heartbeat, reflecting a large pulse pressure and a hyperdynamic circulation. In distributive hypotension, such as in sepsis, as in this patient in the video, systemic vascular resistance is markedly reduced because of pathologic vasodilation. The heart often responds by increasing cardiac output, creating a high flow state. The combination of low vascular tone and high stroke volume leads to bounding pulses and visible capillary pulsations like this. So in a hypotensive patient, findings such as warm extremities, strong peripheral pulses, and signs of a hyperdynamic circulation point toward distributive shock, where the primary problem is loss of vascular tone rather than pump failure or volume depletion. Finally, let's look at obstructive hypotension. In this category, the heart muscle itself may be normal and blood volume may be adequate, but something is physically blocking blood return to the heart. Because of this impact on preload, cardiac output falls, so peripheral pulses are weak, similar to cardiogenic and hypovolemic shock. But unlike hypovolemia, blood is backing up behind the obstruction. That leads to elevated venous pressures, which we see clinically as an increase in jugular venous pressure. The body senses the low blood pressure and responds with sympathetic activation, increasing systemic vascular resistance. So these patients also tend to have cool extremities. So the pattern in obstructive hypotension is high CVP, high SVR, and low cardiac output, with a double up arrow for high CVP because that's the fundamental problem. Here we see an example of markedly elevated jugular venous pressure in a patient with cardiac tamponade. Even with the patient in the upright position, the external jugular vein is visibly engorged, reflecting very high right-sided venous pressures. In cardiac tamponade, fluid in the pericardial space compresses the heart and limits its ability to fill during diastole. Blood returning to the heart cannot enter effectively, so pressure backs up into the venous system. Despite the high venous pressure, forward flow from the heart is reduced, leading to low cardiac output and hypotension. So in a hypotensive patient, a markedly distended neck vein, especially in the upright position, can be a key clue to obstructive shock, where a mechanical problem is preventing the heart from filling or ejecting normally. Now that we understand the physiologic pattern of hypovolemic hypotension, low filling pressures, high SVR, and low cardiac output, we can start filling in the differential diagnosis. In hypovolemic hypotension, the problem is simple. There isn't enough circulating volume to support adequate preload and cardiac output. The most obvious cause is hemorrhage, where blood is lost from the intravascular space. But volume can also be lost through other routes. GI losses, such as vomiting or diarrhea, can lead to significant hypovolemia. Renal losses, particularly from diuretics or osmotic diuresis, can also reduce effective circulating volume. Poor oral intake can gradually lead to hypovolemia, especially in vulnerable patients such as the elderly. And in cases like severe burns, fluid shifts out of the intravascular space into damaged tissues, effectively reducing circulating volume. All of these conditions share the same physiologic endpoint: decreased venous return, reduced stroke volume, and hypotension due to inadequate preload. Now let's move to cardiogenic hypotension. Here, the physiologic pattern is different from hypovolemia. Filling pressures are elevated, SVR is high from sympathetic activation, but cardiac output remains low because the heart cannot pump effectively. Many different conditions can impair the heart's ability to generate forward flow. Cardiomyopathy, whether acute or chronic, reduces contractile function. Dysrhythmias can severely limit effective cardiac output, either because the rate is too fast, too slow, or the rhythm is disorganized. An acute myocardial infarction can abruptly reduce contractility and lead to pump failure. Acute valvular problems, such as severe regurgitation or obstruction, can also impair forward flow. Some conditions limit output by creating resistance to ejection rather than by weakening the muscle itself. Left ventricular outflow tract obstruction is one example. Now let's fill in the causes of distributive hypotension. Here, the defining physiologic problem is loss of systemic vascular resistance due to pathologic vasodilation. Cardiac output may be normal or even increased, but blood pressure falls because the arterial system has lost tone. The most common cause is sepsis, where inflammatory mediators cause widespread vasodilation and capillary leak. Anaphylaxis produces a similar effect through massive histamine release, leading to vasodilation and increased vascular permeability. Certain medications, particularly vasodilators or sedative agents, can also reduce vascular tone. Adrenal insufficiency can impair the body's ability to maintain vascular tone in times of stress, leading to hypotension. Neurogenic shock, such as after spinal cord injury, results from loss of sympathetic tone, causing unopposed vasodilation. And more broadly, forms of dysautonomia can impair vascular regulation and lead to distributive physiology. All of these conditions share the same hemodynamic pattern: low SVR, often warm extremities, and a cardiac output that may be initially preserved or even elevated. Finally, let's fill in the causes of obstructive hypotension. In this category, the heart muscle may be normal and blood volume may be adequate, but something is mechanically preventing normal circulation. Blood cannot fill the heart and cannot be ejected effectively. Cardiac tamponade is a classic example. Fluid in the pericardial space compresses the heart and limits diastolic filling, leading to elevated venous pressures and reduced cardiac output. A tension pneumothorax can have a similar effect by increasing intrathoracic pressure, compressing the great veins and heart, and impairing venous return. And in constrictive pericarditis, a rigid pericardium restricts cardiac filling, leading to chronically elevated venous pressures and a limited stroke volume. All of these conditions share the same hemodynamic pattern: high filling pressures, high SVR from systemic activation, and low cardiac output. So when a hypotensive patient has distended neck veins and signs of poor forward flow, you should think about a mechanical obstruction of circulation, not just pump failure. Now let's return to our patient and use the framework to make sense of his hypotension. He is profoundly hypotensive with a blood pressure of 70/40, and he's tachycardic. So the question is, which physiologic lever has failed? Start with filling pressures. His jugular venous pressure is elevated at 16 centimeters of water. That immediately tells us that this is not hypovolemic shock. The tank is not empty. Now let's look at systemic vascular resistance. His extremities are cool to the touch, suggesting vasoconstriction and a high SVR. That makes distributive shock unlikely, since those patients are typically warm and vasodilated. Now let's consider cardiac output. He's hypotensive, tachycardic, lightheaded, and has weak peripheral pulses, all consistent with low forward flow. So putting this together, we have high filling pressures, high SVR, and low cardiac output. That narrows us to either cardiogenic or obstructive hypotension. Now we look for clues to distinguish between these two. He has bilateral inspiratory rales, suggesting pulmonary edema. He has an extra heart sound just after S2, consistent with an S3 gallop, a sign of volume overload and systolic dysfunction. His EKG shows evidence of an acute ischemic event, and the chest radiograph shows pulmonary congestion. All of these findings point toward pump failure, not a mechanical obstruction. So using the framework, we move from hypotension to cardiogenic shock, most likely due to an acute myocardial infarction with severe left ventricular dysfunction. So to bring this all together, hypotension is not just a number, it's a physiologic problem with a limited set of mechanisms. When you approach it by asking what's happening to filling pressure, vascular tone, and cardiac output, the differential diagnosis becomes structured instead of overwhelming. We saw how hypotension can result from low volume, pump failure, pathologic vasodilation, or mechanical obstruction, and how bedside clues like the jugular venous pressure, skin temperature, and pulse quality can help us rapidly narrow the possibilities. When you think this way, you're not just memorizing causes, you're understanding the physiology that connects the patient's exam to the diagnosis. This framework is the same one I use on the wards, at the bedside with trainees, and in frameworks for internal medicine. It's a practical way to turn a critical clinical problem into something organized, logical, and teachable. And most importantly, it gives you a mental model you can use the next time you're standing in front of a hypotensive patient and need to make sense of what's happening, quickly and clearly.